The Medicare Part D lie that steals your $10,000 drug savings. Margaret did everything right. Same meds, same pharmacy, same Medicare Part D. Then over 3 years, tiny price jumps, and one preferred switch bled her dry, more than $10,000 gone. Let's be honest, this system is confusing on purpose. You see the counter total, not the yearly leak. Don't worry, we've all been there. In the next few minutes, I'll expose the Medicare Part D lie, show you exactly where the money escapes, and give you 3 steps to take it back legally. Step 3 is the one agents hope you never learn. If last month's pill costs more this month, this is for you. The $10,000 drug trap. What's really happening? Here's the quiet lie. My plan covers my drugs, so I'm fine. Sounds safe. It's not. Part D isn't one price. It's a moving system that stacks. For moving parts quietly multiply each other. Stages, formularies, pricing lanes, and timing. If you miss even one, you pay more than you need to. Let me make it simple. Stages decide what you owe as the year goes on. You'll feel January's deductible, then the looks small but stacks copays in initial coverage, then wobble in the gap, and finally relief when you hit the $2,000 out-of-pocket cap for covered drugs in 2025. Formularies decide which drugs your plan favors and which hoops pop up: tiers, prior authorization, step therapy. Pricing lanes are what you actually pay at the counter. Insurance, straight cash, or a discount card. Timing is when and in what order you fill, because January math isn't June math. The trap multiplies in 2 quiet ways: price resets and mid-year switches. When a new year starts, deductibles reset. And the same NDC, same drug, same strength, different manufacturer code, can ring differently. Mid-year, your pharmacy might swap manufacturers, your plan might tweak preferred status, or a quantity limit kicks in. No warning, just a new total. Now add the lanes. Insurance, cash, discount. On the same day, for the same bottle, those 3 lanes can show 3 different prices. Let's be honest, the counter is not built to volunteer the lowest number. You must force a fair comparison. Before you run it, what's today's cash price, your best discount you can honor, and the insurance test claim for this exact strength and quantity? What NDC is that? If they already ran insurance, ask them to void and requote. Pharmacies do test and void all day. You're not being difficult. You're being smart. Here's where timing flips savings from nice to wow. In 2025, once you're out of pocket on covered Part D drugs hits $2,000, most covered fills drop to about $1 for the rest of the year. That means expensive covered meds, brands, inhalers, insulin should usually run through insurance, so those dollars count toward the cap. Meanwhile, dirt cheap generics often cost less with cash or a discount. Shortcut: let expensive covered drugs push you to relief on purpose. Keep cheap meds cheap. But the psychology trap is real. $5 here, $12 there, $19 next refill. No, single total feels scary. By December, the stack is. The system counts on you seeing the counter, not the year. Quick, relatable math. 3 meds, lisinopril generic, $6 to $14 in the cash/discount lane. Sertraline generic, $7 to $22 depending on NDC and lane. Brand inhaler, $60 on insurance or $35 on a discount card. If you pay $15 insurance copays on those generics all year, that's about $360 when the cash/discount lane could be closer to $144. Seems small, but add the inhaler mistake. Chasing a $35 discount on a covered brand might save $25 today, but delay hitting the $2,000 cap, which means you lose months of $1 covered fills later. Across a year or two, that tiny delay turns into hundreds, sometimes thousands, especially if insulin or another brand is in the mix. Order matters too. If you fill 3 cheap generics on insurance January 3rd and delay the expensive covered inhaler. Until March, you spent early dollars in the wrong lane and stretched your runway to relief. Flip it. Front-load the high-cost covered med through insurance early in the year, 30 or 90 days if you're stable. Then route cheap generics to the lowest lane that month. Now, for formulary illusions. Preferred doesn't always mean cheapest at the register. It means the plan struck a deal. A non-preferred generic can still be cheaper as cash. For covered brands, Preferred can lower your copay while the system pays more overall, which can boomerang into next year's premium. Treat Preferred as a hint, not a verdict. Verify live prices across the 3 lanes for the same NDC and day supply. NDC swings quietly change everything. Same drug, same dose, different manufacturer, new price. Your store may auto-switch to a costlier NDC. Ask, which NDC is this? And can you order last month's NDC and hold that price? If yes, request a 7 to 14-day partial now and fill the rest when it arrives. 1 minute of questions beats a year of overpaying. 2 patterns. Leak the most. Auto-refill sleepwalking. If you never reprice, you lock a last month winner into this month loser. Lane confusion. Paying $15 insurance for a $6 generic, then using a discount for a $70 covered brand that should push you to the cap. It feels sensible in the moment and irrational by December. The stack effect is the real villain. Stages plus formularies plus lanes plus timing multiplied by resets and mid-year switches. Each piece is small. Together, they quietly move $1,000 to $3,000 a year out of your pocket, easily $10,000 over a few years for couples on several meds. Don't worry, you don't need a policy degree. You need a clean view of the 4 stages and a simple monthly routine. Coming up, I'll decode the stages, show the week your costs should drop, and give you a counter script that turns whatever the register says into the true lowest number that still supports your plan. Stay with me. The next part is where 90% of people get trapped, and it's the easiest to fix. Decode the 4 stages, where costs spike. Let's decode the toll booths so you can stop paying at the wrong window. There are 4 stages in Part D. Your cost changes as you move through them. Once you see the pattern, you'll know the exact week your total should drop and how to make sure it actually does. Stage 1 is the deductible. This is why January stings and any new drug mid-year can surprise you. Until you meet the deductible, you pay the plan's allowed price on covered drugs. 2 big rules most people miss. 1. Only covered drugs count toward the deductible and the $2,000 cap. Discount card fills usually don't move the meter. 2. A high-cost covered med early can be your friend if you'll stay on it. It clears the gate faster, so later fills get cheaper. Smart move. If you use insulin or a pricey inhaler, line up a 30 or 90-day fill in week 1 when you're stable. If it's a new generic you might not tolerate, keep it to 30 days until you're sure. Stage 2 is initial coverage. This is the looks small but stacks zone that traps 90% of people. You'll see little copays or co-insurance. 5 here, 12 there, 19 next week. It feels harmless. It isn't. This is where choosing the lane wrong costs hundreds by December. 2 simple plays win. First, move cheap generics to cash or discount when they're under about $10 to $15. Don't pay a $15 insurance copay 12 times for a $6 cash drug. Second, keep cap drivers in the insurance lane, so every dollar marches you to the $2,000 cap in 2025. That's the switch that drops most covered meds to about $1 for the rest of the year. If you remember nothing else, remember this. Cheap wins cheap, expensive covered meds count. Stage 3 used to scare everyone. The coverage gap, the donut hole. In 2025, the cap simplifies life. Yes, the behind-the-scenes math still shifts as you move. And brands may wobble because of under-the-hood contributions, but don't chase labels. Ask one question at the counter. Does this film move me toward the cap? If it's a covered cap driver, keep it on insurance. If it's a cheap generic, buy it for less outside the plan. That focus stops the slow leak. Stage 4 is catastrophic, which for 2025 acts like relief. Hit the $2,000 out-of-pocket limit on covered drugs, and most covered fills drop to about $1 through December 31st. That's why timing and order matter. Front load necessary expensive covered meds early in the year on purpose, then enjoy months of $1 fills. Meanwhile, keep bargain generics in the cheapest lane that month. Now, let's talk order of operations, because this is where most people mess up. If you fill 3 cheap generics on insurance January 3rd and push your expensive covered inhaler to March, you've just spent your early dollars in the wrong lane and stretched your runway to relief. Flip it. Refill the high-cost covered med first, 30 or 90 based on stability. Then map your generics across cash and discount for that month's winner. And always match apples to apples. Same drug, same strength, same day supply, and when possible, the same NDC. Here's a simple month 1 blueprint you can copy. Week 1 of January or your plan start. Fill your top 1 or 2 cap drivers through insurance. If you're stable, compare 90-day insurance at preferred pharmacy versus local 90-day and versus 3 30-day locals with a discount. Pick the true lowest that still counts. Week 2, map your cheap generics across cash and discount. Lock the lowest lane and leave insurance out if those meds don't help you reach the cap. Week 3, if a new drug appears, ask your prescriber for a 14-day trial, not 90. Week 4, log your year-to-date covered spending in your plan portal, note your distance to the $2,000 cap, and set next month's order accordingly. Micro story to make it real. A viewer hit January with insulin and a brand inhaler. We filled both on insurance in week 1, then priced their 2 generics as cash. By late spring, they hit the cap. 4. The rest of the year, covered meds rang about $1. If they chased a $35 discount on the brand in February, they would have delayed relief by 2 months and paid more overall. Common mistakes to avoid in stages: treating preferred as cheapest. It's a deal label, not a price tag. Comparing 30-day in one lane to 90-day in another. That picks fake winners. Ignoring NDC. If today's NDC rings higher, ask the pharmacy to order last month's NDC and hold the price. Take a 7 to 14-day partial now. Quick checkpoint. Deductible. Front-load cap drivers if you'll stay on them. Initial coverage. Cheap generics go cash or discount. Keep cap drivers on insurance. Gap. Ignore the name, follow the cap. Relief. Harvest $1 fills for covered drugs after you hit the limit. Next up, the formulary trap that makes a drug disappear without changing your dose, and the timing window that lets you fix it before January locks you in. Agents won't love this part. You will. The formulary trap. Your drug can disappear. Let's be honest, the word formulary sounds like homework, but this is the lever that quietly changes your price without changing your dose. A formulary is your plan's menu. It lists what's covered, which tier it sits on, and what hoops exist: prior authorization, step therapy, and quantity limits. The trap. Covered doesn't mean stable. Tiers can shift in January, and mid-year price jumps can appear when a pharmacy switches the NDC they stock. You don't get a headline. You just see a new total. Why this matters? Do it wrong and you'll pay more, wait longer, and miss your path to the $2,000 cap. Do it right, and you either land a cheaper covered option or you build a clean record that unlocks a tier exception. The game is won with timing, live pricing, and one short message to your prescriber before you're standing at the counter. Here's the simple map. Tiers control your share. Tiers 1 to 2 are usually generics. Tiers 3 to 5 are brands with more hoops. Hoops aren't personal, they steer use. Your power move is to check the hoop early and set the appeal path before you run out of pills. Practical line to your clinic. My plan flags PA/step therapy for drug/strength. Can you submit the PA now? If denied, can we try the plan's preferred option for 14 days while we appeal? That single note cuts a week of phone tag. Mid-year, NDC spite. Same drug, same strength, new manufacturer code, new price. The fix-it pickup. Which NDC is that? Can you order last month's NDC and hold the price? I'll take a 7 to 14-day partial today. If they can't source it, call an independent and ask them to match a public discount as straight cash to avoid card fees. For cheap generics only, keep cap drivers on insurance when you're aiming for relief. Now, preferred is not cheapest. It means your plan cut a deal. A non-preferred generic can still ring lower in the cash lane. A preferred brand can lower your copay, while the plan pays more overall, which can show up later in premiums. Treat preferred as a hint. Always verify live numbers across lanes for the same NDC and day supply. Apples to apples, or you'll pick a fake winner. Therapeutic substitution is where savings live if it's safe. Your move is a 14-day test, not a leap. Script you can copy. Goal. Same effect, lower cost. Live quotes today. Option A preferred. $X insurance /$Y cash. My current drug $Z. If clinically reasonable, can we try option A for 14 days? If not tolerated, can you file a tier exception? You keep safety first and build a stronger appeal because you've documented tried and failed. Open enrollment is your big window. The annual enrollment period runs October 15th to December 7th. Every fall, run a 60-minute compare on Medicare's Plan Finder with your actual drug list, strengths, day supplies, and the pharmacies you use. Test 30 versus 90 days in each lane. Don't chase a low premium that wrecks your tiers. Pick the plan that covers your real life at your real stores. If you know a switch is likely next year, add that drug to your test so you don't get ambushed in January. Quiet windows exist mid-year. 2. If you move zip codes, lose other creditable coverage, or your plan removes a drug or pushes it to a higher tier, you may qualify for a special enrollment period. Document dates, prices, and plan notices. Then ask the plan if your change qualifies. Don't worry, we've all been lost in the rules. The point is you have more than one chance per year. Quantity and packaging can save real money. Some plans favor 90-day insurance bills for stable meds. Discount lanes often favor 30-day for generics. Always price 30 versus 90 in every lane for the same NDC. Ask the pharmacy, is there a pack size that lowers the per tablet cost? If yes, ask your prescriber to align the quantity. You're not changing dose, you're matching the best tier. Micro story. A viewer's sertraline jumped from $9 to $16. Same dose, same store. We asked for the NDC. Different manufacturer. The tech could order last. Month's NDC by Friday. They took a 7-day partial for $3, then filled the rest at $8. 2 questions. 1 reminder, price fixed. Fast prescriber template you can send today. Goal. Same effect, lower cost. Plan flags PA/step therapy for drug. Preferred options, AIB. Live quotes, $X insurance /$Y cash. Current, $Z. Can we try it for 14 days? If not tolerated, will you file a tier exception? Please add OK to dispense generic. May substitute manufacturer, so the pharmacy can source the lowest cost NDC. Short, clear, and it gives the office everything they need. Common mistakes to avoid: waiting until you're out of pills to start a PA, treating preferred like a price guarantee, comparing 30-day in one lane to 90-day in another, ignoring NDC identity and stock. switching a cap driver to a discount card early in the year, and delaying relief. If you remember nothing else, remember this: pair live pricing with a short, safe trial and clean notes. You'll either land a cheaper covered option or earn the exception that keeps your routine and your budget steady. Next, we'll use that paper trail to beat denials, fast drop, painful copays, and leverage programs that cut brand fills to $1.50 without derailing your cap strategy. This is the move agents rarely teach, and it's the one that changes your monthly bill. Timing power, open enrollment, and the quiet windows. Let's be honest, timing feels boring until it saves you real money. With Part D, the calendar is a tool. Use the big window, then grab the quiet ones most people miss. Don't worry, we've all ignored dates before. After this, you won't. Start with the annual enrollment period, October 15th to December 7th. This is your once-a-year chance to switch Part D plans for January 1st. Plans change tiers, preferred pharmacies, and hoops. Your meds don't magically adapt. The trap is clicking re-enroll because last year was fine. The smarter play is a 60-minute comparison that mirrors how you actually feel. Here's the clean routine. Step 1. Update your drug list using your receipts. Write drug, strength, day supply, and your current winning lane by NDC. If you found a cheaper manufacturer, note it. Step 2. Open Medicare's Plan Finder and load your exact list. Add the pharmacies you truly use plus one independent. Step 3. Compare 2 or 3 top plans side by side. Watch yearly totals, tier flags, and whether your stores are preferred. Step 4. Test 30 versus 90 days for every maintenance med in each plan view. Stable? Price 90. Still adjusting? Keep 30. Step 5. Pick the plan that protects your real tiers at your real stores. Trust me on this one. The lowest premium that wrecks your tiers is not a deal. Micro win. A viewer with an inhaler and insulin swapped to a plan that kept both on preferred tiers and a preferred local pharmacy. We front-loaded fills in January. They hit the 2025 $2,000 cap by late spring and paid about $1 on covered meds for months. Same drugs, better timing. Now, the quiet windows. These save your year when life changes. Special enrollment periods can open if you move zip codes, lose other creditable coverage, your plan terminates, or a plan error or mid-year change hits your drug. If a drug is removed from the formulary or bumped to a higher tier after January, document it. Dates, prices, screenshots. Call your plan and ask if the change qualifies you for an exception to switch. You're not being picky. You're asking for the rules they wrote. There's also a simple pre-fill timing edge you can use monthly. 7 days before pickup week, build a fresh price map for only your top 2 expensive meds first. Ask your default pharmacy. Before you run it, what's today's cash price, your best discount you can honor, and the insurance test claim for this exact strength and quantity? And which NDC is that? If insurance already ran, ask to void and requote. Confirm stock, any fees, and 30 versus 90 totals. Then do a quick check for cheap generics. If cash or discount beats your plan by a mile, switch lanes for that month. That 10-minute rhythm catches jumps before they hit your card. Order still matters. Early in the year, put cap drivers, brands, inhalers, insulin through insurance first, so those dollars count toward the 2025 $2,000 cap. Price 90-day under insurance if you're stable and your plan favors mail or a preferred store. Keep bargain generics in the lowest lane that month, often cash or a discount. That split is how you reach relief faster without overpaying on basics. Mail versus local is timing plus stability. Mail can win for stable 90-day covered meds, but it loses during dose changes or while prior authorization is pending. Simple rule: 30-day local while you're stabilizing or appealing, switch to 90-day mail only after the dose is steady and the total beats local after delivery fees. Ask, is shipping free? Per order or per item? Which NDC will ship? A $6 per item fee can erase the win. If mail can't name the NDC, pause. Pick the reliable local price this month and recheck next month. 2 more timing levers you can pull anytime. 1. Prescriber heads up. When your clinician mentions a likely switch, ask them to check the plan's preferred alternatives now and prep a prior authorization with a short, tried and failed list. That way, if the change lands in January, you're not stuck in the deductible waiting. 2. Appeal clocks. If a denial hits, request expedited review and abridge supply right away. Put follow-up dates on your calendar. Faster approvals equal fewer cash bridges and more dollars counting toward the cap. Monthly cadence you can copy. Week 1. Fill cap drivers through insurance. Price 90 versus 3 by 30 smartly. Week 2. Map cheap generics across cash and discount and keep them in the lowest lane. Week 3. Any new med gets a 14-day trial before 90. Week 4. Log covered out-of-pocket year-to-date and your distance to $2,000. Adjust next month's order. October to December. Add the 60-minute plan compare and lock next year's tiers by December 7th. Quick mistakes to avoid. Waiting until January to find out your plan hates your pharmacy. Comparing a 90-day insurance quote to a 30-day discount and picking the fake winner. Assuming delivery is free. And letting a mid-year tier bump slide without asking about a special enrollment period. If you remember nothing else, remember this. Use the big window to set your year, use quiet windows to fix surprises, and use the pre-fill week to stop leaks before they start. Timing isn't boring. It's how you pay the real lowest number and get to $1 covered meds sooner. On purpose. The 3 lanes: insurance, cash, discount cards. Now we put the lanes on one field so you can choose on purpose. At every counter, there are 3 lanes: insurance, straight cash, and discount card. None is best all the time. The job is simple. Force a side-by-side for your exact drug, strength, day supply. And NDC, then pick the lane that's cheapest without hurting your cap strategy. Let's be honest, the register won't volunteer the lowest number. You'll use one clean line. Before you run it, what's today's cash price, what's the best discount price you can honor, and what's the insurance test claim for this exact strength and quantity, and which NDC are those for? If insurance already ran, ask them to void, so you can compare cleanly. Pharmacies do test and void all day. Here's the simple default that keeps you out of trouble. Expensive covered meds, brands, inhalers, insulin, or anything usually over about $50 if covered. Try insurance first, so those dollars move you toward the 2025 $2,000 cap. That's how you unlock $1 covered fills later. Cheap wins. Generics that consistently ring under about $10 to $15 often go cash or discount when they clearly beat insurance. Break the default only when a live quote proves otherwise, and it won't sabotage your path to relief. Why this works? Insurance is a counting lane for covered drugs. Those dollars build to the cap. Discount cards are a separate cash lane that can beat insurance on some generics, but usually don't count toward your deductible or the cap. Cash is the store's own price and can be matched by independents to avoid card fees. 3 lanes, 1 decision. Price, policy, impact. Make your comparison apples to apples. Same drug and dosage form. IR versus ER is not interchangeable. Same strength and day supply. Price 30 versus 90 separately. Ask for the NDC behind each number. Manufacturer and pack size swing the total. NDC control is your quiet lever. If last month's NDC rang $8 and today's is $16, ask which NDC is that, and can you order last month's NDC and hold that price? I'll take a 7 to 14 day partial today. If your chain can't source it, call an independent and ask them to match a public discount as cash to avoid card fees. That move saves on generics. For cab drivers, keep them on insurance when you're aiming for relief. Fees can flip winners. Ask, any dispensing fees, delivery charges, or membership needed for that price? Is delivery per order or per item? A $6 per item fee can double a $7 generic. If a fee erases the win, pick curbside or ask an independent to match as cash. Let me show you exactly how this plays out with a quick 3x3 routine. Pick 3 pharmacies you'll actually use, 1 national chain, 1 big box or grocery, 1 independent. Check 2 or 3 discount apps you trust plus straight cash at each store. Capture 5 numbers for each drug, insurance test claim, store cash, and the lowest discount price each app offers for that store. Note the NDC behind each. Micro story for clarity. A viewer's Sertraline rang $19 via insurance at a preferred chain. Cash was $13. A discount showed $7 tied to a specific NDC. They asked to void the insurance test, honored the $7 discount, confirmed the NDC, and paid $7 in 10 minutes. Next month, the independent matched $6 as cash to avoid the card fee. Same drug, same strength, same day supply, different lane, different NDC, half the cost. Quantity matching avoids fake winners. Don't compare a 30-day discount to a 90-day insurance quote. Ask, what are the 30-day and 90-day totals in each lane for this exact NDC? If you're stable and insurance wins at 90, great. If you're still adjusting, keep 30-day until the dose is steady, then switch to 90 once the numbers and timing line up. One more lane twist nobody tells you. Discount card rates can change by store location, even inside the same chain. Pull a fresh code for the exact address you'll use. If you switch stores, refresh the quote. If privacy matters, ask the pharmacy to match a public discount as cash so your data stays local. Common mistakes: treating preferred pharmacy like always lowest. It's a hint, not a price. Forgetting NDC identity and stock. Ignoring delivery or membership fees that erase savings. Using a discount on a cab driver early in the year and delaying relief. Bottom line, compare before anyone runs a claim. Confirm the NDC and fees. Choose lanes by impact, not just sticker. Let expensive covered meds push you to the cap on purpose. Keep cheap meds cheap. And use the 3x3 check to surface real winners in minutes. This is how you stop paying whatever shows up and start paying the true lowest number that still supports your plan. The agent's least favorite move: appeal and win. Let's be honest, denials feel personal. A screen flashes prior authorization, step therapy, or non-preferred tier, and your brain goes, great, more hoops. Don't worry, we've all been there. Here's the twist agents rarely push. Clean appeals work a lot. More than people think, and fast, when you follow a tight playbook. This is the move that drops a $90 copay to $10, keeps dollars counting toward the 2025 $2,000 cap, and steadies your month. Why this matters? Every day you wait, you either overpay in the wrong lane or skip doses. Both cost more than one short call and one clear message to your clinic. Your goal is simple: convert a denial into a covered fill or a tier exception, so your share drops while every dollar still helps you reach relief. Here's the 3-piece packet that wins: your letter, your prescriber's note, and a short tried and failed list. Think contractor bid, scope, evidence, result. Part 1, your letter, 2 short paragraphs. Who you are, the drug, strength, dose, and what happened, prior authorization required, step therapy, or non-preferred tier. Then the ask, coverage approval or a tier exception to the lowest applicable tier. One key line: alternatives names were tried and caused ineffective/side effects, as noted in my prescriber's letter. Close with, I'm requesting expedited review because treatment is ongoing. Part 2, prescriber support, the backbone. Ask your clinician's team for a brief note that states the diagnosis, why this drug is medically appropriate, and a bulleted tried and failed list with simple dates and outcomes. End with request prior authorization approval or tier exception. Alternatives were ineffective or not tolerated. Make it easy. Send your plan info and the plan's fax/upload details they use daily. Part 3. Attachments that close loops. A recent chart note or med list. A screenshot of the plan's formulary requirement, PA/step, and, if helpful, receipts showing ongoing therapy. That's it. Clean, specific, fast. Now timing. Start the clock the same day. Call the plan for the case ID. Ask for expedited review. Put follow-up dates on your calendar. 48 to 72 hours is common. If denied, request the written reason and address that reason directly in the reconsideration with your prescriber's added detail. You're not being pushy. You're being organized. Bridge supplies prevent gaps while the appeal runs. At the counter say, can you provide a 7 to 14-day supply while the PA processes? If insurance can't allow it, pick the lane by impact. If this is a cap driver and you'll likely hit the $2,000 cap, ask the plan for a temporary override or transition fill. So those dollars count. If not possible, use the cheapest lane for a short bridge, then flip back to insurance the moment approval lands, so the spend helps you. Tier exceptions are the quiet hero. They don't change the drug, they change your share. You're line to the plan. I'm requesting a tier exception to the preferred tier because alternatives failed or are unsafe. This move often turns a painful brand copay into something predictable and affordable without derailing your path to relief. Let me show you exactly how this looks with a tight script to your clinic you can copy. Goal, same effect, lower cost. Plan flags PA/step 4, drug/strength. Tried and failed, a date/outcome, B date/outcome. Can you submit PA? And, if needed, a tier exception? I'm requesting expedited review. I'll run out by date. Please include OK to dispense generic. May substitute manufacturer. So the pharmacy can source the lowest cost NDC. Short, kind, complete. Micro story. A viewer's inhaler jumped from affordable to painful after a tier change. The plan wanted step therapy. Past notes showed jitteriness and poor control on the preferred alternative. We sent the 3-piece packet, the member letter, the prescriber's note citing prior intolerance and risk, and the tried and failed bullets. We asked for a tier exception specifically. Approval landed in 72 hours. Copay dropped. Every dollar counted toward the cap. And 2 months later, they were paying about $1 on covered meds. 2 common mistakes to avoid. Vague appeals. It's expensive is not a reason. A caused tachycardia on March 12th. B failed after 4 weeks. Patient requires C due to COPD. Is specific and wins. Waiting for the pharmacy to fix it. They can nudge. You and your prescriber own the clinical story. Start the clock yourself. Manufacturer. Help can bridge brand costs without wrecking your plan. Many copay cards can't be used with Part D at the register, but patient assistance programs listed on sites like MediMeds may offer no-cost medication if you qualify. Ask your prescriber for samples for a week. Apply the same day you appeal, and keep cap drivers in insurance once approved so dollars still move you toward relief. Quick phone script to your plan. I have a denial for drug. I'm requesting expedited review. Case ID? What documents do you need? If approval is pending, can you allow a short transition fill? So I don't miss doses. Notes, dates, names written down. If you remember nothing else, remember this. Fast, specific appeals work. Use the 3-piece packet. Ask for expedited review and a tier exception when appropriate. Secure a bridge supply. And keep cap drivers in insurance, so every dollar pushes you toward the $2,000 cap. This is the move agents rarely emphasize, and it's the one that lowers your bill while your plan does the counting for you. Manufacturer assistance, patient programs, and mail tricks. Let's be honest, brand prices can still sting even after a win. Don't worry, we've all stood at the counter doing the math. Here's the move agents rarely hype because it takes a little extra effort. And it's worth it. You'll stack 3 tools: patient assistance programs for big drops, in-store price levers for quick wins, and smart mail timing that saves without surprise fees. Start with manufacturer patient assistance programs, PAPs. These are separate from copay cards and can help people on Medicare. You apply through the brand's program, and if you qualify, they may provide the medication at no cost for a period. Use a reputable directory like Medicare to find the exact program by drug name. You'll usually complete 3 pieces: your short form, your prescriber's form, and proof of income. Ask your clinic if they've done this for other patients. Most have a routine and can upload paperwork fast. Here's your quick script to the clinic. Goal: same effect, lower cost. I'm applying to the manufacturer's patient assistance for drug/strength. Can your team complete the prescriber section and send the last chart note? I'll attach the program link and my plan info. Keep it short. Attach the link you found on Medimeds and your case details, so they're not chasing you for basics. Bridge while the PAP processes. Ask your prescriber for samples if they have them, then request a 7 to 14-day supply at the counter. If this brand is a cap driver and you'll likely hit the 2025 $2,000 limit, call the plan and ask for a temporary transition. Fill while approval is pending, so those dollars count. If the plan can't, use the cheapest lane for the short bridge, then flip back to insurance the minute you're approved, so the spend helps you reach relief. Now, let's talk in-store levers that quietly drop totals. First, internal coupons and store programs. Ask, do you have a store program or internal coupon for this drug? If they quote a number, confirm the lane. Is that cash, discount, or insurance? You want to know whether it counts toward your cap. If it's a cash mechanism and the drug is not a cap driver, take the win. If it is a cap driver and you'll reach the cap, keep it on insurance, and work the price down through tier exceptions and PAPs, so every dollar moves the meter. Second, NDC sourcing. If last month's NDC priced lower, ask, can you order that NDC and hold the price? I'll take 7 to 14 days today. If your chain can't, call an independent and say, can you match this public discount as cash to avoid card fees and order NDC code by Friday? Independents often meet you halfway because they skip the discount network fee. Third, packaging and day supply. Ask, is there a pack size that lowers the per tablet cost? Then, align the script. If you're stable and insurance wins at 90 days, do it. If your mid-adjustment or a PA is pending, stick with 30 days to avoid buying pills you may not use. And remember the rule we set earlier. Never mix 30-day quotes against 90-day quotes when you choose a lane. Apples to apples, or you'll pick a fake winner. Now the mail trick, done right. Mail can beat local for stable, covered 90-day meds, but fees can flip the winner. Your questions: is shipping free? Is it per order or per item? Which NDC will you ship? A $6 per item fee can double a cheap generic. If shipping is per order, align multiple 90-day meds to ship together after approvals, so you pay the fee once. If the mail pharmacy won't name the NDC, pause. Choose the reliable local price this month, and recheck mail next month when stock stabilizes. Micro story. A viewer won a tier exception on a brand. Local 30-day was still high. We priced 90-day mail under insurance, 90-day local, and 3 30-day locals with discounts. Mail won only after we confirmed free shipping per order, not per item, and the exact NDC. we aligned 2 other 90-day meds to ship together. Total dropped, weeks of quiet refills, and every dollar still counted toward the cap. If they'd guessed on fees or NDC, they would have paid more. One more high-leverage tweak. Ask your prescriber to add, "Okay" to dispense generic, may substitute manufacturer. That sentence lets the pharmacy source the lowest cost NDC without ping-ponging your clinician for tiny changes. Pair that with your monthly pre-fill map, and you'll catch price jumps before they land. Common mistakes to avoid: treating copay cards like a silver bullet on Part D. Most copay cards can't be used with Part D at the register. PAPs are the right path. Applying late. Start the PAP the same day you file the appeal or tier exception. Ignoring fees. Delivery charges can erase a win. Buying 90 days. During dose changes. Do 14 days to test, then 30, then 90 when steady. Moving a cap driver to a discount card early in the year and delaying relief. Quick checklist you can read off your phone. Needy Meds program found and links saved. Clinic message sent with plan info and program link. Samples or 7 to 14-day bridge secured. Tier exception filed if needed. Expedited review requested. NDC confirmed. Cheaper NDC ordered if available. Mail fees verified. NDC verified. Shipments aligned per order. If you remember nothing else, remember this. PAPs drop the bill, NDCs drop the sticker, and mail timing locks in the total, only when fees are known and doses are stable. Stack those with your appeal wins, keep cap drivers in insurance, and you'll watch scary totals turn into predictable refills while you march to that $1 relief on covered meds. Your 10-minute monthly drug cost check. Let's make this simple and fast. 10 minutes once a month, the week before pickup. You'll update prices, confirm NDCs and stock, choose lanes by impact, and track how close you are to the 2025 $2,000 cap on covered Part D drugs. Don't worry, we've all skipped money chores. This one pays you every month. Minute 1. Open your notes where you saved last month's winners. Make 1 line per active med. Drug, strength, day supply, last winning pharmacy, lane, price, and NDC. Star your top 2 expensive covered meds. Those are your cap drivers. Minute 2, remove noise. Archive stop meds. Treat dose changes like a new drug, you must reprice. If a pharmacy switched manufacturers last time, circle that med for an NDC check. Minute 3, for your 2-star cap drivers, call your default pharmacy and say, before you run it, what's today's cash price, what's the best discount price you can honor, and what's the insurance test claim for this exact strength and quantity, and which NDC is that? If they already ran insurance, ask to void and requote. Pharmacies do test and void all day. Minute 4, confirm identity and availability. Is that NDC in stock? If not, when can you get it? And will the price hold? Any dispensing or delivery fees? Note per order versus per item shipping if mail is involved. Fees flip winners fast. Minute 5, price 30 versus 90 for the same NDC in each lane. If you're stable and insurance wins at 90, great. If you're still adjusting or a prior authorization is pending, keep 30. Do not compare a 30-day discount to a 90-day insurance quote. Apples to apples, or you'll pick a fake winner. Minute 6, sweep your cheap generics. Ask cash, best discount honored, and only if there's a chance insurance wins. An insurance test claim. If a generic totals under about $10 to $15 in cash or discount, it likely belongs outside insurance this month. Keep cap drivers on insurance, so those dollars count toward the cap. Minute 7, track your cap progress. Log 1 line at the top of your notes. Covered OOPYDD. Dollar, distance to $2,000. Your plan portal shows this. Call member services if needed. This single line drives decisions. If you're close to the cap, lean on insurance for cap drivers. If you're far, chase absolute bottom cash / discount on cheap meds. Minute 8. Decide lanes by impact, not just sticker. Quick rules. Expensive covered meds try insurance first, so they push you toward $1 covered fills later. Cheap wins stay cheap. Break defaults only when a live quote proves otherwise, and the change won't sabotage the cap strategy. Minute 9. Lock details so pickup is boring. For each med, write pharmacy, lane, final price, NDC, fees, 30 versus 90 choice, and whether it counts toward the cap. Save screenshots of discount codes tied to the exact store address. If an NDC needs ordering, ask for a 7 to 14 day partial now, and the rest when it arrives. Minute 10. Prescriber touch. If any med priced badly 2 months in a row, send a short message. Goal. Same effect, lower cost. Live quotes today. Option A versus current. If clinically reasonable, can we try preferred for 14 days? If not tolerated, will you submit a tier exception? Please add OK to dispense generic. May substitute manufacturer. That single note unlocks safer switches and smoother appeals. Now, 2 micro stories, so this sticks. A viewer's fluoxetine jumped from $9 to $16. They ran this routine, learned the NDC changed, asked the store to order last month's NDC, took a 7-day partial for $3, then filled the rest at $8 when it arrived. 1 call, money back. Another viewer with insulin and a brand inhaler kept both on insurance, priced 90-day under the plan's preferred channel, and bought their sertraline as $7 cash after confirming the NDC. They hit the cap by late spring. Covered meds rang about $1 for months. Common mistakes to avoid: comparing mismatched quantities or formulations, ignoring delivery or membership fees, letting auto refill lock you into a losing NDC. Turn auto refill off for any med you might move, using a discount card on a cap driver early in the year and delaying relief, trusting last month's screenshot, pull fresh same-day quotes. Your wallet card you can read at the counter, cash price today, best discount you can honor, insurance test claim for the same. Which NDC are those for? Any fees? 30 versus 90 totals? If I use discount today, does it count toward my cap? If you remember nothing else, remember this. Compare before anyone runs a claim, confirm the NDC and stock, choose lanes by impact, and log your covered out-of-pocket, so you know exactly when $1 covered meds should start. 10 minutes a month turns chaos into calm, and calm into real savings. Talk to your prescriber like a pro. Let's be honest, nobody wants to sound difficult at the clinic. Don't worry, we've all felt rushed in the portal. Your goal is simple. Same effect, lower, predictable cost without derailing safety or your 2025 cap strategy. When you lead with clear numbers and safe options, prescribers move fast because you make the decision easy. Start every message with outcome plus live quotes. Goal: same effect, lower cost. Today's numbers for sertraline 50 milligrams, 30 tablets, $7 cash at independent using NDC 123, $19 insurance at chain, $13 cash at chain. Can we optimize for the $7 option? That single opener does 4 things. Names the outcome, shows you've priced apples to apples, proves it's not guesswork, and respects their time. Now, the 3 levers most people miss: formulary alignment, per milligram math, and safe quantity shifts. Formulary alignment is your first check. If your plan flags prior auth or step therapy, say plan flags PA/step 4, drug/strength. Preferred options are A, B. If clinically reasonable, can we test it for 14 days? If not tolerated, will you submit a tier exception? That 14-day test protects safety and builds a clean, tried and failed record, which strengthens your appeal. Keep cap drivers in insurance, so those dollars still push you toward the 2025 $2,000 cap. Per milligram math can drop the price without changing your daily dose. Ask, is it safe to use a higher scored strength and split? For example, one 20 milligrams tablet instead of two 10s. Only if the tablet is scored and not extended release or enteric coated. Confirm with your prescriber and pharmacist. Then price both strengths across lanes for the same NDC. When the higher strength costs less per milligram, you win quietly. Quantity shifts matter more than people think. If you're stable and insurance wins at 90 days, request 90 under the plan's preferred channel, mail or local after you confirm fees, and the exact NDC. If you're adjusting dose or waiting on a PA, stick to 30. Trust me on this one. A cheap 30 that fits this month's facts beats a 90 that locks you into the wrong math. Here's a tight template you can copy word for word. Goal: same effect, lower cost. Live quotes today. Preferred option $X insurance /$Y cash for NDC code. Current drug $Z. Plan flags PA/step for current. If clinically reasonable, may we try option A for 14 days? If not tolerated, will you submit a tier exception? Please include OK to dispense generic. May substitute manufacturer, so the pharmacy can source the lowest cost NDC. Why include may substitute manufacturer? Because NDC swings change price. That line lets the pharmacist source the cheaper manufacturer without ping-ponging the office for every small swap. You keep the molecule, you lower the sticker. When safety is the concern, history of side effects or comorbidities, lead with facts. Tried citalopram. Palpitations on day 6, March 14th. Tried escitalopram. Ineffective after 4 weeks, 04/18, 05/15. Current sertraline controls symptoms. Requesting tier exception to preferred tier due to tried and failed. Specific names, dates, outcomes. That's what wins. Micro story. A viewer's brand inhaler flipped tiers mid-year, and the copay stung. The plan pushed a preferred alternative that had caused jitteriness before. We messaged the clinic with the 14-day trial ask, attached the prior intolerance note, and priced mail 90-day under insurance after approval. The trial failed fast, which strengthened the tier exception. Approval in 72 hours. Copay dropped. Every dollar counted toward the cap, and 2 months later they were paying about $1 on covered meds. Make the dose switch safe and simple. If splitting is on the table, ask for clear instructions. Scored tablet, split once daily with a proper splitter, never for ER or enteric coated. Then confirm with the pharmacist at pickup. If the tablet isn't scored or the pharmacist flags a risk, stop. Savings never outrank safety. When a generic didn't agree with you, be precise. Many reactions are about excipients from one manufacturer, not the molecule. Ask, can we try the same generic from manufacturer X that avoids dye Y? Please add OK to dispense generic. May substitute manufacturer. Then price that NDC across lanes. If it controls symptoms and prices well, you're done. If not, your tier exception request is stronger. For timing, pair your clinic message with your monthly pre-filled check, so everyone moves once. Send the note right after you build your price map. Include screenshots or the exact numbers plus the NDC. End with a next step that matches clinic workflow. If the alternative works, please send a 90-day to pharmacy where pricing is lowest. If not tolerated, I'll message in a week to request a tier exception. Short, clear, respectful. 2 guardrails to avoid expensive mistakes. Don't jump to 90 days during a dose change or while a PA is pending. Do 14, then 30, then 90 when steady. Don't split ER or enteric-coated tablets. When in doubt, ask the pharmacist first. If you need to move fast after a denial, attach your tried and failed bullets and ask the office to submit both the PA and the tier exception together with an expedited request. Then ask the pharmacy for a 7 to 14-day bridge while it processes. Keep cap drivers in insurance. When you're likely to hit the cap, use cash or discount bridges for cheap generics. Close every message with gratitude and clarity. Thanks for helping me keep the same effect at a lower, predictable cost. I'll confirm stock and NDC with the pharmacy and follow up with results. That tone keeps the door open. Bottom line, lead with your goal, bring live numbers, and the NDC protect safety with short trials, and give the office the exact words that move paperwork. Do that, and you'll turn clinic messages into lower bills, faster approvals, and a smooth path to those $1 covered fills once you hit the 2025 cap. 2 quiet traps, delivery fees, and dose games. Let's be honest, these 2 sound tiny. They aren't. Delivery fees quietly double cheap meds, and dose games raise your price per milligram without you noticing. Catch both in under 2 minutes per fill, and you keep real money in your pocket. Trap 1, delivery and convenience fees. A $6 delivery on a $7 generic? That's a 100% markup. Memberships, rush options, per item courier charges. Each looks small, but over 12 fills they wipe out your discount. Before you accept delivery, ask 3 questions. Is delivery free? If not, is the fee per order or per item? Can multiple prescriptions ship under 1 fee? If it's per item, switch to curbside or bundle refills so they ship together. Warehouse clubs can be great, but verify if membership is required for that exact price. If a fee erases the win, ask an independent to match a public discount as cash so both of you avoid card fees. Micro win. A viewer paid $7 for a generic, then added same-day delivery for $6. Boom, $13 total. Next month they bundled 2 scripts under 1 free order, used curbside for the 3rd, and stayed at $7. Same meds, same month, different total. All because of a tiny button. Trap 2, dose games that inflate your per milligram price. A small change in strength or formulation can raise your monthly cost even if your daily dose doesn't change. Your move is simple. Ask for per tablet and rough per milligram cost before you accept a change. What's the total for 10 milligrams versus 20 milligrams? And which has the lower price per milligram? If one scored 20 milligrams tablet costs less per milligram than 2 10s, and your prescriber approves splitting, you save. Never split extended release or enteric-coated tablets. Confirm with your clinician and pharmacist first. Safety beats savings, always. Immediate release versus extended release is the classic convenience tax. ER can be helpful, but IR sometimes costs far less. Ask your prescriber, if clinically reasonable, could I use immediate release twice daily instead of extended release once daily? Then price both formulations across lanes for the same NDC and day supply. If adherence would suffer, keep ER and chase savings via NDC Sourcing, pharmacy choice, and pack size instead. Pack size traps are real. A 56-count blister can price worse than a 60-count bottle for the same month's dose, or vice versa. Ask the pharmacy, is there a pack size that lowers the per tablet cost? If yes, have your prescriber align the quantity. You're not changing your dose, you're matching the cheapest packaging tier. Therapeutic cousin swaps can bump you into a higher insurance tier or a discount dead zone. Before you accept a similar alternative, say, can we check insurance tier and discount quotes for that option? So the monthly total is actually lower? If the new drug rings higher, stick with your current therapy or pursue a tier exception with tried and failed documentation. Quick dose math script at the counter. For this exact NDC, what's the per tablet price for 10 milligrams and 20 milligrams? Which one has the lower price per milligram? If my prescriber approves a scored split, that's the value path. Then pair it with the cap strategy. If I use this lane today, does it count toward my $2,000 cap? Pick savings that don't sabotage relief. fees checklist you can read off your phone. Delivery free, per order, or per item. Can multiple scripts ship under one fee? Any membership required for that price? Are there dispensing fees or taxes not in the quote? Dose checklist you can copy. Is a higher scored strength safe to split? Never ER or enteric coded. Per tablet and per milligram totals for both strengths. Same NDC. 30-day and 90-day totals in each lane for the same NDC. Does this change, help, or hurt my path to the $2,000 cap? Micro story. Lisinopril 10 milligrams twice daily rang $14 with a discount. We asked per mg math. The 20 milligrams scored tablet was $6 for 30. Prescriber approved splitting. Tablet was scored, not ER, and the pharmacist confirmed the cheaper NDC. Monthly cost more than half with zero clinical change because they ran per mg math before they paid. Common mistakes to avoid: paying delivery per item on $7 generics, bundle or use curbside. Comparing 30-day in one lane to 90-day in another. Splitting without approval or splitting ER/enteric tablets. Accepting a similar drug without checking the real monthly total. Ignoring pack sizes and NDC identity. Bottom line, don't let fees double a cheap win, and don't let small dose tweaks raise your per milligram cost. Ask the fee questions up front. Run the per mg check, match quantity to the best pack, and keep your cap strategy intact. 2 minutes per fill, real money back. The 12-month plan to hit the cap early, on purpose. Let's be honest, have a plan sounds boring. This one isn't. It turns a messy year into months of $1 covered meds once you hit the 2025 $2,000 out-of-pocket limit on covered Part D drugs. Don't worry, we've all winged it before. Now, we'll run a simple year that pays you back. Start with 2 buckets. Bucket A is cap drivers. Brands, inhalers, insulin, or any covered med that usually runs $50 plus per fill. Bucket B is cheap wins. Generics that ring under about $10 to $15 in cash or discount lanes. Start your top 2 in Bucket A. They're your engine to reach relief fast. Your default rule: Bucket A runs through insurance, so dollars count. Bucket B stays in the cheapest lane that month. January, front load on purpose. Week 1, fill your starred Bucket A meds through insurance. If you're stable, compare 90-day insurance at a preferred store or mail versus local. Pick the winner that still counts toward the cap and doesn't add fees. Week 2, map Bucket B across cash and discount for this month's NDC winners. Keep insurance out unless it clearly beats cash. Week 3, any new med gets a 14-day trial, not 90. Week 4, log covered OOP YDD and distance to $2,000. Trust me on this one. This first month sets the glide path. February, March, stay on the gas. Keep Bucket A on insurance. If a tier bites, file a PA or tier exception now using your 3-piece packet. Ask for expedited review and a bridge supply. For Bucket B, keep using the cheapest lane by live price and NDC. Do your 10-minute monthly check before pickup. If mail wins for a stable Bucket A drug and shipping is free per order, align refills so multiple meds ship together. April, quarter turn. Message your prescriber with live quotes and request, okay to dispense generic. May substitute manufacturer. If stable, move eligible Bucket A meds to 90-day where insurance wins. If a trial switch is coming, start now with a 14-day test while you're not rushing into summer travel. Update your log. Note progress to $2,000. May, June, mid-year audit. Reprice your top 2 cap drivers across lanes and pharmacies. Ask your default store to source last month's cheaper NDC. Take a 7 to 14-day partial while it ships. Confirm delivery or membership fees that quietly flip winners. If you're within a few $100s of the cap, Lean into insurance for all CAP drivers. Keep Bucket B off insurance unless it's truly cheaper there. July, appeal tune-up. If one brand is still painful, escalate the tier exception with specific tried and failed bullets. Request expedited review and a transition fill. Don't skip doses. Keep CAP drivers in insurance, so every approved dollar counts. If you're already at the cap, celebrate quietly. Covered meds should ring close to $1 through December 31st. Keep Bucket B cheap by lane. August, September, steady state. Lock any stable Bucket A meds to 90-day under the winning channel with known NDCs and no hidden fees. Align shipment dates to reduce hassle. Keep your monthly 10-minute price check. If an NDC changes, fix it fast with a partial plus order. Small moves, big calm. October, open enrollment prep. Spend 60 minutes on Medicare's Plan Finder. Load your exact drugs, strengths, day supplies, and real pharmacies. Test 30 versus 90 for maintenance meds in each plan. Pick the plan that protects Bucket A tiers at your real stores. Don't chase a low premium that wrecks your tiers. If your prescriber hinted at a switch next year, add that drug to your compare. November, December, execute. Confirm the new plan, note any likely PAs, and ask your clinic to pre-prepare a PA template with tried and failed bullets. Reprice your January fills before the holidays. Stock an extra 14 days for weather or travel. Turn off auto refill on any med you might move. Monthly cadence, repeatable in 10 minutes. Week 1, fill Bucket A through insurance. Price 90 versus 3 by 30. Week 2, remap Bucket B across cash and discount. Pick the lowest lane. Week 3, 14-day trials for new meds. Avoid 90 until stable. Week 4, log covered OOP YDD and distance to $2,000. Adjust next month's order and message the clinic if a med stayed high 2 months in a row. Micro story. A couple with insulin and a brand inhaler front-loaded both on insurance in January moved the inhaler to 90-day mail only after confirming free shipping per order and the exact NDC, and kept sertraline as $7 cash at an independent that matched without card fees. They hit the cap by late spring. For the rest of the year, covered meds rang about $1. The difference wasn't luck, it was order lanes and one monthly check, common pitfalls, and fast fixes. Filling 3 cheap generics on insurance in January while delaying your cap driver. Flip it, comparing 30-day in one lane to 90-day in another. Apples to apples. Ignoring delivery fees. Ask per order versus per item. Using a discount on a cap driver early in the year. You'll delay relief. If you remember nothing else, remember this. Aim Bucket A at the cap on purpose, keep Bucket B cheap, reprice monthly, and set October time to choose next year's tiers. Simple, repeatable, and it pays you back with months of $1 covered meds. The emergency playbook, when prices jump. Let's be honest, price shocks feel personal. One day it's $9, the next it's $16, and your brain goes, "Did I miss something?" Don't worry, we've all been there. Here's the clean, fast playbook that turns a bad surprise into a non-event in under 10 minutes. You'll identify what changed, stabilize a short supply, and route back to the lane that supports your 2025 $2,000 cap strategy. Step 1. Identify the change. Say this line at the counter. Which NDC is this price for? And did the manufacturer change since my last fill? If yes, ask, can you order last month's NDC and hold that price? I'll take a 7 to 14-day partial today. If they can't source it, call an independent and ask them to match a public discount as straight cash to avoid card fees. For cheap generics only, keep cap drivers on insurance when you're aiming for relief. Step 2. Confirm the 3 lanes cleanly. Read your wallet card. Before you run it, What's today's cash price? What's the best discount price you can honor? And what's the insurance test claim for this exact strength and quantity? And which NDC are those for? If insurance already ran, say, could you void that so we can compare cleanly? Pharmacies do test and void all day. You're not being difficult. You're avoiding a bad lock-in. Step 3. Choose the lane by impact, not just sticker. Quick rule. Cap drivers, brands, inhalers, insulin. Try insurance first so dollars count toward the 2025 $2,000 cap. And unlock $1 covered fills later. Cheap wins. Generics ringing under about $10 to $15. Often go cash or discount when they clearly beat insurance. Break the default only when a live quote proves it, and you won't sabotage relief. If you hit a denial, start the clock the same day. Call the plan for a case ID and request expedited review. Then ask the pharmacy for a bridge. Can you provide a 7 to 14-day supply while the prior authorization processes? If insurance can't allow it, decide your bridge lane by impact. If you'll reach the cap, ask the plan for a temporary transition fill, so those dollars count. If not possible, use the cheapest lane for a short bridge, then flip back to insurance when approval lands. Fees can turn wins into losses. Ask, any dispensing fees or delivery charges? Is shipping free per order or per item? A $6 per item fee can double a $7 generic. If a fee erases the win, use curbside, bundle refills, or ask an independent to match as cash. Timing matters. Early in the year, refill cap drivers first in the month, so those dollars count toward the cap sooner. Keep cheap generics in the lowest lane that month. If this happens the week before pickup, run the pre-fill price map for your 2 most expensive meds first, then sweep generics. 10 minutes now saves months of overpaying. Micro story. A viewer's fluoxetine jumped from $9 to $16 at pickup. We asked, which NDC? Different manufacturer. The tech could order last month's NDC by Friday. They took a 7-day partial for $3, then filled the rest at $8 when it arrived. Same drug, same dose, new total, because they asked 2 questions before paying. If stock is the issue, ask lead time and lock a partial. When will that NDC arrive? Can I get a 7 to 14-day supply today? If the lead time is long, transfer just that prescription to a store that confirms stock and price. Turn off auto refill at the old pharmacy for that drug so you don't trigger an accidental claim in the wrong lane. If a tier changed mid-year and your copay spikes, get the facts first. Is this now non-preferred or a different tier? Ask for plan-preferred alternatives by class, then message your prescriber. Goal: same effect, lower cost. Live quotes: preferred a $X insurance / $Y cash. Current $Z. If clinically reasonable, can we try it for 14 days? If not tolerated, will you submit a tier exception? That 14-day test protects safety and strengthens your appeal. Your 60-second emergency checklist. Which NDC is this? And did the manufacturer change? Can you order last month's NDC and hold the price? Partial today. Cash, best discount honored. And insurance test claim for the same strength, quantity, and NDC, any dispensing or delivery fees. Shipping per order or per item. If denied, case ID, expedited review, and a 7 to 14-day bridge or transition fill. Common mistakes to avoid: comparing a 30-day discount to a 90-day insurance quote. Fake winner. Using a discount on a cap driver early in the year delays relief. Forgetting fees and memberships. Small buttons, big totals. Waiting until you're out of pills to start a prior authorization. Start the clock now. Letting auto refill keep a losing NDC. Turn it off on any med you might move. Bottom line: identify, stabilize, and then choose the lane by impact. Ask the NDC question, confirm fees, secure a bridge if needed, and route cap drivers through insurance, so every dollar pushes you toward $1 covered meds. Price shocks aren't personal, they're procedural. Use the playbook and make them boring. The 7-day rapid savings sprint. Let's be honest, big plans feel heavy. So here's a fast 1-week sprint that proves this works. 7 short tasks. Real dollars back by your next pickup. Don't worry, we've all put this off. This time, you'll have a script in your hand and a win by day 3. Day 1, map your top 2 cap drivers. Pick the 2 most expensive covered meds, often a brand, inhaler, or insulin. Call your default pharmacy and say, before you run it, what's today's cash price, your best discount price you can honor, and the insurance test claim for this exact strength and quantity? And which NDC is that? If insurance already ran, ask to void. Note fees and 30 versus 90 totals. Star the lane that both counts toward the 2025 $2,000 cap and prices best this month. Day 2, map 1 cheap generic the same way. Use the exact drug, strength, day supply, and NDC. Check 2 other pharmacies, 1 big box or grocery, and 1 independent. If a discount wins, screenshot the code tied to that store address. If privacy matters, ask the independent to match as straight cash to skip card fees. Apples to apples, or you'll pick a fake winner. Day 3, message your prescriber with live quotes. Use this exact note. Goal, same effect, lower cost. Live quotes today. Preferred option, $X insurance /$Y cash. NDC code, current $Z. If clinically reasonable, can we try option A for 14 days? If not tolerated, will you submit a tier exception? Please add OK to dispense generic. May substitute manufacturer, so the pharmacy can source the lowest cost NDC. That one message starts the appeal clock and unlocks safer switches. Day 4, file 1 clean appeal or tier exception. Use the 3-piece packet, your letter, prescriber note, tried and failed bullets with dates and outcomes. Call the plan, get the case ID, and request expedited review. Ask the pharmacy for a 7 to 14-day bridge. If this is a cap driver and you'll likely hit the cap, ask for a temporary transition fill. So those dollars count. If not possible, bridge with the cheapest lane and flip back to insurance at approval. Day 5, NDC sourcing and partial. For any drug that jumped, ask your store, can you order last month's NDC and hold the price? I'll take a 7 to 14-day partial today. If a chain can't source it, call an independent. Can you match this public discount as cash to avoid card fees and order NDC code by Friday? You lock continuity and avoid paying for the wrong bottle. Day 6, mail versus local sanity check. For 1 stable covered med only, compare 90-day mail under insurance versus 90-day local versus 3 30-day locals discount. Ask, is shipping free? Per order or per item? Which NDC will ship? Fees flip winners. If shipping is per order, align another stable med to ship together. If mail won't name the NDC, pause and pick local this cycle. You're buying calm, not guesswork. Day 7, lock lanes and cancel landmines. For each prescription, write the winning pharmacy, lane, final price, NDC, 30 versus 90 choice, fees, and whether it counts toward the cap. Save discount screenshots tied to the exact store. Turn off auto refill for any med you might move, so a clerk doesn't auto-lock the wrong lane next month. Add a single line at the top, covered OOPYDD. Dollar, distance to $2,000. Dollar, that line steers every decision. Micro stories, so you feel the payoff. One viewer's Sertraline jumped to $16. They asked the NDC question. Ordered last month's NDC, took a 7-day partial for $3 and finished at $8. Another viewer filed a tier exception on a brand inhaler with tried and failed dates. Approval in 72 hours, copay dropped, and every dollar counted toward the cap. A third lined up 90-day mail only after confirming free shipping per order, and the exact NDC then aligned a second med to the same box. Quiet refills, lower totals. Common mistakes and quick fixes mixing 30-day and 90-day quotes across lanes. Price both quantities in each lane first. Using a discount on a cap driver early in the year. Keep cap drivers in insurance to reach relief sooner. Ignoring fees. Ask per order versus per item. Memberships can erase savings. Waiting until you're out of pills. Start PAs and exceptions with a 14-day trial cushion. Forgetting NDC identity. Write it down. It's the barcode behind the price. Wallet card to read out loud. Cash price today? Best discount you can honor? Insurance test claim. Same strength, quantity, NDC? Any fees? 30 versus 90 totals? Does this count toward my $2,000 cap? If you remember nothing else, remember this. 7 tiny moves: map, message, appeal, partial, verify NDC, check fees, lock lanes, turn next month's bill from surprise into predictable. 1 week, real wins, and a simpler path to those $1 covered fills. Proof moments, micro stories that lock the lesson. Quick wins prove the system. 10 tight stories, real numbers, simple moves. Lisinopril, $52 to $6, same counter. A viewer heard preferred pharmacy and paid $52 under insurance. We ran the 3-lane line, matched 30-day to 30-day, asked the NDC, and saw $6 via a public discount tied to a different NDC. They asked to void the test claim, honored the $6 code, and saved in 10 minutes. Next month, the independent matched $6 as straight cash to avoid card fees. Sertraline, jump fixed with one question. Price went from $9 to $16. We asked, which NDC? Different manufacturer. The store ordered last month's NDC, gave a 7-day partial for $3, then filled the rest at $8. Same drug, same dose, new total, because they checked identity before paying. Inhaler versus discount card, sticker versus strategy. A $35 discount looked sweet next to a $60 copay. They also used insulin. We kept both in the insurance lane on purpose. They hit the 2025 $2,000 cap 2 months earlier and paid about $1 on covered meds for the rest of the year. The expensive choice won across the year. Mail win that only worked with fees checked. After a tier exception, 90-day mail beat local by $18, only after confirming shipping was free per order and naming the exact NDC. We aligned a second 90-day to the same box. No surprise fees, comma refills. Levothyroxine, brand myth broken by manufacturer. Brand Synthroid was $42. A previous generic didn't agree. We targeted a different manufacturer's generic, added okay to dispense generic, may substitute manufacturer, and priced that NDC $9 cash at the big box one. Tolerated, then 90-day where it priced best. Fluoxetine, 30 versus 90 apples to apples. A chain showed $28 for 90-day with discount. Mail insurance was $1 after the cap, and the independent quoted $23 for 90-day discount. They chose mail once steady. Fewer trips, lower spend. Metformin, independent beats chain by 61%. Chain was $18 with a card. Independent cash was $7 tied to an NDC. The chain next month matched as cash to avoid card fees. Live numbers, same month, less money. COPD alternative trial powers exception. Preferred alt caused jitteriness before. We ran a 14-day test, documented intolerance, filed a tier exception, 1 in 72 hours, and moved to 90-day mail with free per order shipping. Copay fell, dollars counted, delivery fee trap dodged. A $7 generic plus $6 same-day delivery doubled the total. Next month, they bundled 2 meds under 1 free order and used curbside for the third. Back to $7, not $13. The Cap on Purpose couple. January week 1, they filled insulin and a brand inhaler through insurance, priced 90-day under the plan's preferred channel, and bought Sertraline as $7 cash with the correct NDC. By late spring, they hit the cap. For months, covered meds rang about $1. If you remember nothing else, remember this. Ask the NDC, match quantities, confirm fees, choose lanes by impact, and front-load cap drivers. Small moves, big calm. Rapid recap and set up for action. Let's be honest, this system is confusing on purpose. You don't need a PhD. You need a simple playbook you can run on autopilot. Here's your tight recap and the exact moves to start today. First, the core rule that saves the most money fast. Choose lanes by impact, not just sticker. Let expensive covered meds, brands, inhalers, insulin run through insurance on purpose, so those dollars push you toward the 2025 $2,000 Part D cap and months of $1 covered fills. Keep cheap generics cheap with cash, or a discount when they ring under about $10 to $15. Break the default only when a live quote proves it, and it won't sabotage your path to relief. Trust me on this one. This single rule flips the year in your favor. Second, force a fair fight at the counter. Before anyone runs a claim, ask, what's today's cash price? What's the best discount price you can honor? And what's the insurance test claim for this exact strength and quantity? And which NDC are those for? If insurance already ran, ask them to void, so you can compare cleanly. Pharmacies do test and void all day. You're not being difficult. You're choosing smart. Third, control the NDC. Prices swing by manufacturer and pack size. If last month's NDC was cheaper, ask the store to order it and hold the price. Take a 7 to 14-day partial today, then fill the rest when it arrives. If a chain can't source it, an independent often can, and may match a public discount as straight cash to avoid card fees. That one question turns most $9, $16 jumps back into $8. Fourth, beat the small but stacked stage. The initial coverage stage looks harmless. $7 here, $12 there, but it's where 90% gets stuck. Front load cap drivers early in the year and early in the month, so you hit the cap faster. Keep cheap wins outside insurance unless insurance clearly beats cash. That's how you turn months of UGG into months of $1 covered fills. Fifth, appeal faster than you think you need to. A clean 3-piece packet, your short letter, your prescriber's note, and tried and failed bullets. Wins often and quickly. Ask for expedited review, and when appropriate, a tier exception. Request a 7 to 14-day bridge while it processes. Keep cap drivers on insurance, so every dollar counts toward the cap once. It's approved. Don't worry, we've all felt intimidated by paperwork. Use the exact lines we gave you. It's rinse and repeat. Sixth, fees flip winners. Always ask if delivery is free per order or per item. A $6 per item fee doubles a $7 generic. Bundle shipments under 1 free order. Use curbside, or switch the 1 med to your deal pharmacy. Small buttons change big totals. Seventh, mail is a tool, not a default. Mail can win for stable 90-day covered meds, but only when shipping is free and the NDC is named. If the mail pharmacy won't specify the NDC, pause and take the reliable local price this cycle. Then recheck next month. Eighth, do the 10-minute monthly check. Week before pickup, price your 2 most expensive meds first across cash, discount, and insurance. Same strength, same quantity, same NDC. Then sweep your generics. Log 1 line. Covered OOP YDD. Dollar, distance to $2,000. Dollar dot. That line steers. every choice. Close the loop with one short clinic message if a med has been overpriced 2 months in a row. 9th, run the 7-day sprint once. Map 2 cap drivers and 1 cheap generic, message your prescriber with live quotes, file 1 appeal or tier exception, secure a 7 to 14-day bridge, source the right NDC, sanity check mail versus local with fees, and lock lanes while canceling auto refill landmines. 7 tiny moves, real dollars back next pickup. 10th, the emergency playbook. If a price jumps, ask the NDC question. Secure a partial, confirm the 3 lanes cleanly, pick the lane by impact, and start the appeal clock the same day, if needed. Price shocks aren't personal, they're procedural. Use the checklist and make them boring. Your day 1 starter list you can literally read off your phone. Before you run it, cash, best discount you can honor, insurance test claim. And which NDC, any fees or delivery charges, is shipping free, per order or per item. 30-day and 90-day totals in each lane for this exact NDC. If I use discount today, does it count toward my $2,000 cap? Which NDC is this? And can you order last month's NDC and hold the price? And your week 1 sprint in 3 lines. Map 2 cap drivers and 1 cheap generic. Same drug/strength/quantity/NDC at 3 stores. Message your prescriber with live quotes and the 14-day trial/tier exception plan. File 1 clean appeal, request expedited review, and lock a 7 to 14-day bridge. Let's be honest, you don't need to memorize policy. You need a routine. Compare before anyone runs a claim. Confirm the NDC and fees. Choose lanes by impact. Appeal fast with a 3-piece packet. Track your covered out-of-pocket, so you know exactly when $1 covered meds should start. Do that, and the Medicare Part D lie loses its power because you're holding the map. Here's the takeaway. Force the 3 lanes to compete. Let expensive covered meds push you to the cap, and use fast, clean appeals to lock in predictable prices. If you want momentum today, run the 7-day sprint. And then watch the next video where I show plan comparisons step by step. Subscribe for weekly traps and fixes, and share this with a friend who's overpaying so they can save now.